Welcome to Podcast UK. In this episode, we're looking at management of neuroma.
Hello and welcome to this episode, which is all about neurometer. I'm Matt Stone, I'm a plastics registrar from Yorkshire, and for this episode you're spoilt by having two brilliant speakers. We have Mr Kavit Amin, an academic clinical lecturer at the University of Manchester, who has a particular interest in restoring form and function after limb loss and impairment. And we also have Mr Sanjib Majumder, a consultant plastic surgeon from the Mid Yorkshire Teaching Hospitals NHS Trust. Welcome to you both.
Hi, Matt.
Hi, Matt.
So, neurometer can be a challenging problem, can't they? Can you explain a little bit about what they are and how they develop?
I think the first thing to say is that we're seeing essentially a paradigm shift in the management of neuroma, because there's many ways that have been described in terms of how to manage this difficult clinical problem. So there's lots of tools within that surgical toolbox. Going back to what you were asking, a neuroma is essentially uncontrolled healing of a nerve. So you get this disorganized mass of Schwann cells and axons. And the belief is that this is caused by perineural injury. So when the perineurium is breached, what happens is you get axons that interact with inflamed tissues in the surrounding area, and that can lead to fibrosis and then pain signals that are sort of targeted towards the central nervous system.
Is there a way of classifying neurometer?
Neuromas can be classified into neoplastic, so for example, acoustic neuromas, or non-neoplastic, which are traumatic neuromas. And that's what we're going to see most often, and that's what we're going to focus on within this discussion. You can get what we call an end neuroma. So when we do an amputation, you have the raw surface of the nerve that's sort of exposed, buried within the soft tissues, right through to neuroma in continuity, which we'll probably discuss a bit more later, where you actually have a nerve that's in continuity with a neuroma within it. Not all neuromata are problematic. You'll find that people will have neuromas where they don't have any symptoms at all. And you'll also get neuromas that are very problematic.
So how do these patients typically present? I mean, what features in the history are helpful when making this diagnosis?
So if somebody's had trauma within that region, or you can see that there is a scar that's present there, or they've had a tight calf, for example, they will also give you a history of neuropathic pain problems. So they may have, for example, tingling, sharp electric shock-like discomfort. They may have a lot of hypersensitivity to touch. And there can also be some triggers, for example. The mechanism of injury is also important, because if you have had what you'd consider quite a traumatic injury, for example, where there is a lot of scar, because when nerves get entangled in scar, that can also trigger pain towards that central nervous system, then you would expect that they will have worsening problem and symptoms. So what you want to do is establish the level of the dysfunction that this individual is having. And, what is it that they're trying to achieve? What treatment have they had so far? Are they under the pain team, for example? Which analgesia do they take? And preferably it's a patient that you've operated on. You want to try and get the operation note, for example, or speak to people that have done the operation previously, just to try and gauge exactly which structures might be involved.
And I guess moving on to examination, what's important when you examine these patients to help make that diagnosis?
So looking for any obvious scars that may suggest any previous injury or any previous surgery that they've had. Also, at Tinel's is important to look for advancing regeneration, and you may find that Tinel's isn't progressing beyond that scar where that neuroma is, because we often say that nerves will regenerate at a millimeter a day. So if it's a nerve repair that you've performed, then you'd expect that Tinel's would progress from proximal to a more distal site. And they can sometimes also get neuropathic features, the odd things like a bit of redness, for example, a bit of swelling that just doesn't quite look right.
And are there particular locations where neurometer are more likely to arise or where they can be more problematic?
So it goes without saying that wherever you have sensory branches, especially those that are close to the skin surface, then you will have problems. So superficial branch of the radial nerve, and this is obviously a nerve that you're always asked to try and look for when you're doing anything around the wrist and the hand. You have the superficial perineal nerve, sural nerve, again, very superficial, can cause real problems as well. And often you'll see less problems with those that are sort of more deep-seated, but then have a lot of motor control. So tibial nerve, for example, and that sort of fits with that profile we were talking about before about being entangled in scar as well, and also that you will have innervation into the skin at times, and people will report allodynia or even just small triggers where they're wearing a watch, or they have, some sort of stimulus that will then trigger that pain.
And so we've got the history and the examination findings. What role do diagnostic tests play in this condition?
There are different ways to investigate. And also, you may want a roadmap for surgical planning. EMG nerve conduction studies aren't as useful as you'd expect. Whenever we hear nerve, we think that they may have a role. But all this will tell you is that there's zero latency or any transmission of any nerve activity from one point to another. What is useful is to do an ultrasound. An ultrasound, you'll be able to see that there's a swelling there in the region of where that previous trauma was. If the neuroma is quite deep-seated, for example, sciatic nerve, then you're better off getting an MRI, because it's going to be very difficult with ultrasound to try and characterize that nerve. And also you want help in terms of your surgical planning as well, moving forward. The other thing that we tend to employ quite a lot is the use of local anesthetic. So if you inject local anesthetic at the site of that neuroma, and this can also be done via ultrasound guidance, and if the pain stops, you've pretty much got your answer, that it's a neuroma. The problem is being caused at that particular place, peripherally. If the pain doesn't improve, then this is looking at a more centralized process. So, for example, phantom limb pain doesn't respond to these local anesthetic blocks. Complex regional pain syndrome, for example, won't respond as well. So what you're trying to do is to see, if I was to perform surgery locally in that region to improve things, will it benefit? And so if the pain is improved, then you know that surgery may help and is likely to help. If it doesn't go, then it's unlikely to help.
Yeah, I can't agree with Kavit more, really. It's terribly important that the first step of the management of a neuroma is actually getting the correct diagnosis, because there's so many other neurological things that can mimic the symptoms and sometimes the signs of neuromata. So one has to, use the history, which is a huge part of everything, the examination and the investigation, and put them together. And then even if you've diagnosed that there is a neuroma, which in fairness most times is a reasonably straightforward diagnosis, the decision about what management to institute has to be thought about carefully. In an MDT approach is what I would suggest, and certainly in conjunction with the patient and over a period of time. What you don't really want to do is to go and do some sort of intervention that either doesn't make the patient any better or, even worse, worsens the symptoms for the patient. That would be catastrophic.
So what are the non-surgical treatment options for these patients?
So non-surgical treatment options will include analgesics, so non-steroidals, which is an anti-inflammatory, because this is an inflammatory process. Neuropathic medications like gabapentin, pregabalin, but it's important to mention that they can have side effects as well. You have steroids that individuals have used. I've never used that. Physiotherapy is not to be underestimated. So what the physiotherapists can do is they can provide exercises to try and soften the tissues within that region, soften the scar, and essentially try and avoid that entrapment within that scar. And also desensitization as well, which is a complex thing to understand. This almost is because it's a very central process. There's a discord between the central nervous system and the peripheral nervous system. So what you're trying to do is to send feedback to the central nervous system that everything is okay and that the nerve doesn't need to respond and behave in a threatened way. However, the reality is that about 70% of patients won't respond to these measures that I've just mentioned. And this often leads us to consider then surgical interventions. The other thing that's very useful is ultrasound-guided local anesthetic infiltration. It doesn't need to be ultrasound-guided, but you want to make sure that you're in the right place. There is radiofrequency ablation, and various things like neuromodulation, spinal cord stimulation, but these are very much at the extreme end.
I guess ideally what we want to do is to prevent neuroma formation in the first place. What steps can we take to try to minimize this risk in our practice?
Yeah, that's a really good question, Matt. And the reason I say that is before we actually get into the discussion of the surgical management of the established neuroma. It's a bit like a keloid scar, prevention of a neuroma when you can do so is terribly important, because once a neuroma is already established, the management, as we will discuss, whilst there are various ways to manage it, none of them are 100% efficient. So prevention, well, it's good old-fashioned gentle tissue handling, use of magnification to identify and protect nerves, of course, knowing the anatomy of the area. Now, remember that you don't have to cut a nerve to create a neuroma. You can harm it in other ways. And one of some common ways of doing it is traction. And a really good example of that is when people are doing de Quervain surgery to release the first dorsal space, and they injure the superficial branch of the radial nerve. And a lot of the time it's not that they've cut it, but it's the retraction causes traction injuries to the nerve. Or another thing that people don't realize is thermal injury. And when you're using bipolar, you don't actually even need to hold a nerve between your forceps to cause it a thermal injury. You have the heat that's dissipated for little areas around the actual diathermy point. And if you have a superficial branch of the radial nerve hanging around, it can potentially get thermal injury. So these things are quite important to remember. So no traction injury, no thermal injury, and obviously look for the nerve and don't cut it. The other thing is, even after the operation, ensure that you don't have any compressive dressings which might be tight around the nerve. You put on a nice tight dressing and that stays there for a while, and nerve can get injured because of that. And these things can trigger neuromas quite happily.
What do you do if a nerve's divided by someone who's not able to repair it?
If there is a nerve that's divided, then we should aim to try and repair this as early as possible, and to provide a good quality nerve repair. Early intervention is key. So you may have seen BOAST guidelines, and that's essentially saying that any nerve injury that's caused from other specialties, that this is repaired and promptly referred to plastic surgery as soon as possible. We have referrals into our peripheral nerve service frequently from colleagues, and I think it's really important that we aim to try and get these referred as soon as possible. And this can be from a cannula, for example, or we've had nerve blocks, especially in the popliteal space. This is often from lines that can be inserted, because the important thing to bear in mind is that veins often travel next to nerves. And so wherever people are trying to perform an intervention, that can cause a nerve injury inadvertently if you're unsure of your anatomy.
So those are kind of principles when you're operating around nerves. What if you have to cut a nerve, say, if you're amputating a finger?
Yeah, so the digital amputation and the incidence of a problematic, painful neuroma is, reasonably high. And you got to understand something, that we go on and on about stiff digits and flexor tendons and such like. A stiff digit defunctions a digit. A painful digit will defunction an entire hand, or in fact may actually defunction the person if the pain becomes bad enough and escalates over time. I have a fairly simple approach to how I deal with the digital nerves when I'm doing an amputation. I do a traction neurectomy. So essentially, I will dissect the nerve as far as I can, and then I will pull the nerve, and under tension, divide the nerve as far as I can from the point of where I'm holding it. This then allows the nerve to retract. What I'm trying to do is to get the nerve away from the tips of the amputation stump, where the patient will be using to hold things, so that there isn't any pressure on the nerve ending there, and also get it away from the scarred area, which is again near the tips of the amputation stump. One has to remember that once you've cut a nerve and you haven't repaired it, the incidence of neuroma is 100%. It's the incidence of problematic or painful neuroma that we're trying to decrease. So that's how I do it. I know there are people who bipolar the end or crush the tip. These are not things I particularly understand the rationale behind, but certainly I don't do that. I think, Kavit, you mentioned there's something else you've seen people do, haven't you?
What studies have found is that actually the direction of nerve cutting can have an influence on traumatic neuroma formation. So when you cut the nerve end obliquely, this seems to display a better outcome compared to when you do it perpendicularly or transversely. And the thought is that this is because you have long and short nerve fibers where a growth pathway will be formed between them. So rather than axonal sprouting out with the nerve, it appears that there is interactions between these long and short nerve fibers.
Oh, that's really interesting and not something I'd heard before.
The other thing, Matt, that is used quite widely, especially for sort of major amputations like lower limb and such like, is installation of local anesthetic perineurally at just before the nerve is divided. And by perineural, I don't mean into the perineurium, but rather around the nerve. And that's supposed to decrease the formation of problematic neuromas. Obviously, as I said, you will get a neuroma forming, but it's supposed to decrease the incidence of problematic neuromata as well as phantom pain and such like. Exactly how that works for a relatively short-acting local anesthetic, even though it's a few hours long, because you will use something like bupivacaine. People don't actually know. There's a bit of research going into it, but certainly something that is being used. Kavit, have you seen that in practice?
I have seen that when we have used nerve catheters for end neuromas. I would try and bathe it all the time, if I can.
And now thinking about the situation where you have an established end neuroma, what are the surgical techniques we can use to manage this?
Right. So, Kavit will tell you all about the stuff that is being used now that he's doing research on. And they, as Kavit said before, there's been a paradigm shift in how the established neuromata are actually addressed. In my years of practice, and we started end neuromas, for instance, in the first situation, the techniques we use are what we call passive surgical or ablative techniques. And, it involved cutting the nerve to make it a bit shorter and make it retract, as we did with the digital nerve, the traction neurectomy. You have a huge shift was in the 80s when they started doing excision and implantation. And essentially that means you excise the neuroma, free up the nerve, and then stick it into something else. And the something else could be either bone, a bit of muscle, or sometimes a vein. Now, the concept there is that you're not changing that the neuroma is going to form, but you're putting it into something that is less likely to be pressed. It is away from the superficial parts of the body, and as such, less likely to be painful. That's the concept behind it. So another technique is central neurography, which is a surgical technique to either manage painful neuromata or to prevent painful neuromata, especially after an amputation. And this entails is suturing the cut ends of two nerves, for instance, two digital nerves to each other, to create a closed loop. That's the theory behind it. If there's only one nerve and it's a bigger nerve, for instance, a neuroma and a median nerve, one can split the nerve longitudinally and essentially create two nerves with nerve endings and then coap them together to create the closed loop. This is a technique which was quite popular a few years ago, but really the popularity has waned. People have tried putting nerve caps on to, putting material on top to prevent, again, for them to be painful. Relocation nerve grafting, where essentially you take the nerve and you put a nerve graft onto it and relocate it to another destination. So not hugely dissimilar to sticking it into a bit of muscle or bone, but it's not only relocating it to a less painful destination, but it allows, at least theoretically, for a bit of dissipated nerve growth through the long graft, so you don't have a big neuroma at the end. But, all of these are ablative procedures. And look, at the end of the day, when you cut a nerve, the nerve wants to grow into a bit of tissue and innervate it. Now, the analogy I like to use to explain the differences between the ablative passive techniques and the active surgical or reconstructive technique that Kavit is going to tell us about is the difference between incarceration and rehabilitation for someone who may have done something wrong. I mean, one of the concepts behind incarceration is to protect the public outside the prison from the individual inside prison. And that's the sort of situation you're thinking about when you put a nerve and stick it into a bit of bone or into a bit of muscle. Now, there's enough evidence to show that rehabilitating a person rather than incarcerating them is far more useful, both for the person and for society at large, as you're giving this individual a raison d'etre, if you will. Now, similarly for nerves, we can rehabilitate nerves rather than incarcerate them in bone or muscle or whatever tissue we want to put them into. And this is what Kavit is going to speak about, because the nerves, the inherent raison d'etre is one to go and innovate something. And if we could harness that desire of the nerve to go and re-innovate something, well, that, as Kavit will tell us, will yield much better results.
Yeah, that's actually a really nice way of putting it. So traditional teaching and approaches have used ablative, while what the modern sort of thought process is to look at regenerative, which you could then argue is, in your sort of analogy, is rehabilitative. So you may have heard of targeted muscle reinnovation. This was pioneered by Todd Kuiken in the early 2000s. And this concept mostly came from the US military, with the development of very advanced prostheses, where if you have a proximal amputation, say of an upper limb, there are only so many muscle targets where you can extract those EMG signals. So what Todd Kuiken's group did is they rerouted the large peripheral nerves, so say, for example, the median nerve, and what they did is they implanted them into different muscle targets just before it enters the muscle. So pectoralis has multiple branches, for example. And if you take that large nerve and if you implant it into the branches supplying pectoralis, what will happen is when you have median nerve function, for example, you will have then a contraction within that muscle unit. What they found by doing this is that all of a sudden the pain was being abolished. So some people had a lot of neuroma type pain. Sometimes it was phantom limb type pain. And this technique now has really sort of opened the gateway of mitigating pain, either at the index procedure, where you're first doing that amputation, or, for example, if you're doing a stump revision and you're going to treat that neuroma. The other concepts that's widely being discussed at the moment is RPNI, and this stands for Regenerative Peripheral Nerve Interface, and this has been developed by Paul Sederna over in the University of Michigan. It's been about 10 years now since they've first been using this in patients. Very simply, what they do is they take some devascularized muscle, and that can usually be in the field of surgery that you're in, and they will, depending upon the size of the nerve, they will tease the nerve open so that you might have, for example, sciatic nerve, maybe 3 or 4 bundles of fascicles, and you wrap the nerve like a burrito into this muscle that has no vascular supply. The key then is to place this non-vascularized muscle into a vascularized pocket, because you want to be out of the zone of trauma. And as that muscle vascularizes, what happens is you get innervation from that nerve that wanted a function, and this seems to reduce pain. And likewise, they've also shown that this can increase myoelectric targets as well for advanced prostheses. But importantly, a lot of the meetings that I go to and discussions on webinars will try and compare these two approaches. It's not so much a comparative thing, it's actually looking at the patient that you have in front of you and the problem that you have in front of you, because some patients won't benefit from TMR just because of the proximal dissection that might be needed. Or for some patients, they would benefit from an RPNI. Or some people are now doing mixed approaches where they'll do a TMR. And then for some other smaller nerves, for example, that they have within the field, they may do an RPNI. And this got me thinking in terms of going back to the traditional teaching about burying into the vascularized muscle. Why is it that this devascularized muscle seems to work? And I went to go visit the group that developed the technique, and they said it's all about competitive re-innovation. So if you have muscle that's already innervated, it doesn't allow a new nerve to enter its space for re-innovation because it's already innervated. So if you have devascularized muscle, as that becomes vascularized, this then prevents that this then develops what we call a stopgap, and it's a blank slate, so to speak. And it appears that in the imaging studies, that wherever this nerve regeneration takes place, it doesn't seem to go out with that vascularized muscle pocket, because that's often the one thing that's asked. Will it go out? Can the axons continue to sprout outside of this RPNI? And it doesn't seem to. It seems to stop there. And another fascinating thing that we're going to hear, which is just on the frontier, is this composite RPNI. And this is a really interesting concept that sort of makes sense, but at least now it's been proven and shown that if you get a full thickness skin graft, and if you deepithelialize it, and if you get your devascularized muscle, but this time you're putting your nerve in between the two, and there is a technique to it, suturing technique, but it's something that most plastic surgeons will be able to perform, that the sensory fibers prioritize going towards the dermal template and the skin, and the motor fibers are going towards the muscle. And this is really exciting because it's showing that actually those nerve endings have a choice of where they actually want to go. And in my mind, that's telling me where they will be happiest. And a happy nerve, I would assume, would mean less pain and discomfort. And so they will eventually start a trial looking at the composite RPNI versus the RPNI. So it's almost like a bit of an upgrade on the traditional RPNI that's discussed. So it's important that I just sort of clarify that when mentioning TMR and RPNI, this is for an end neuroma where you don't have the distal segment anymore to coapt onto. The ideal would be for a primary nerve repair in the first instance, if it's a new injury, for example. However, if some time has elapsed, what you want to do is to, do your neurolysis and to trim back the nerve until you have healthy bleeding fascicles, and that you can often tell that because the axons almost want to sprout out, and you have bleeding edges on the end. Try and do a primary repair, but again, what you don't want is a tight repair. So if the repair is tight, the important thing is making sure that you remove all of that scar and you trim back towards healthy fascicles. And if you then have a nerve gap, then your options are autograft. And patients and surgeons don't like this because then you're violating another donor site, for example, which may cause a further neuroma. And you have allograft as well, which is expensive. There are other things that have been described, such as using vein conduits with morselized muscle, where you can chop the muscle up and put it in between the vein for a short gap. And there are conduits as well that are available, synthetic conduits, for example.
Yeah, that's absolutely correct, Kavit. It's quite interesting because I went to a conference in Bahrain a few years ago, and I met Dr. Al-Katan, who's very prolific in his writing, very bright, very affable gentleman, and he was talking about end-to-sign neuropathy.
Oh yeah,
I really have problems pronouncing that word. And he was doing it for people who had neuromata associated with superficial branches of the radial nerve. And he suggested that you make an epineural window, but obviously not traumatize the recipient nerve. So essentially, he took one of the other branches of the superficial branch of radial nerve, made a slight slit in the epineurium, and stuck the nerve where the neuroma had been. So obviously, you excise the neuroma first, and he was very keen on that. Some people aren't keen because they say again you are violating another nerve. But I think the whole idea is to give that nerve a sort of runway for the nerve with the neuroma.
It's a good point actually, and actually it does work for. I'm just thinking in terms of our nerve transfer, so AIN to ulnar nerve, for example. That's not end to end. That's end to side. So I can see how that could work.
Yeah, so I think it's yet another tool in our toolbox, isn't it? Because regrettably, none of the tools work 100% of the time. But yeah, I think it's a fascinating technique.
Or hypoglossal nerve transfer. So we do it, don't we? Because even hypoglossal will be taking part of the hypoglossal nerve and then burying it end to side. So onto facial nerve.
Yeah, exactly.
So we've talked at length now about end neuromas, but what about neuromas in continuity? What are the management options for those?
Yeah, so this is where the nuanced thinking and decision making really becomes important, because you see, in an end neuroma situation, essentially the nerve has been transected completely. So there is no function that that nerve has. The problem with the neuroma in continuity is that part of the nerve is still functioning well, and you don't really want to necessarily go and transect the entire nerve, because then you may downgrade the function, and you got to work out what you're going to do. So the history is terribly important. You got to look at what function the patient actually has, what symptoms do they have, and if you're going to convert a neuroma continuity to an end neuroma, are you willing to sacrifice the function? And it may be that the function is actually quite little, a little bit of sensory input. But if you've got good motor function in a mixed nerve, for instance, you're certainly not going to go and necessarily divide that and downgrade the motor function. So you've got to really unpick this situation, have a detailed discussion with the patient. And I would definitely include the physiotherapist involved in that. The other option is to do a selective neurectomy. So essentially, under magnification, ideally under microscope, pick out the neuroma and then essentially dissect out the axons and fascicles from which the neuroma emanates. And that sounds ideal, except you look, a neuroma is not only bits of nerve tissue which are disorganized, but also bits of scar. So it can become quite tricky. And also, because of the scar, you can then go and injure intact bits of nerve that makes matters worse. Okay, so the management options are not dissimilar to the end neuroma, but actually deciding on whether you should do anything surgical at all, that is the big question for neuroma and continuity. Okay, Kavit, anything more to say on that? Anything from your experiences?
No, but I agree. It's a very challenging decision, which you need to take with the patient about whether you would want to do an operation in this case, because anatomically speaking, everything looks like it's intact, but it really is then again based upon, seeing the patient multiple times, reviewing their sort of clinical course, and whether it's an absolute dead end. But I think I agree with everything you said.
So we've talked about lots of different techniques, and one of the things that we've said is that often the results are not as satisfactory as we might wish. What are the reasons for this?
Well, I wish I knew the answer to what are all the reasons, and we certainly don't know. There's a huge amount of research going into it to try to get that magic bullet. But one of the things is that we don't, nerves aren't like blood vessels. You connect two blood vessels that have been divided and blood flows and hurrah, everybody's happy. But nerves are so much more complex. And there's this whole element of pain centralization, isn't there? And essentially, what that means is there's an element of pain that becomes a part of the central nervous system. And the process and timing of this pain centralization is variable. And not uncommonly, however, patients with long-standing neuropathic pain tend to have this pain centralization, and they certainly have worse outcomes. The exact causes of pain centralization are likely complex and multifactorial. And as I say, it's not clearly understood, but it's likely a reorganization of the somatosensory cortex, which occurs at some point after the nerve injury and neuroma formation. And there also appears to be sort of ongoing progressive cortical reorganization that carries on with time. But this is not hard and fast at present. There's a lot of research going to try to understand an extremely complex process. And that sort of segues me into the sort of whole CRPS type 2, because, we have CRPS type 1, where is chronic regional pain syndrome without a nerve injury, but type 2, you often have a neuroma, or at least a nerve injury can pinpoint. But what triggers a person with a neuroma or a painful neuroma to then develop CRPS? We don't quite know.
With CRPS, it's very ill understood, and we have found that there's things in the literature to suggest that TMR and RPNI are both very helpful with CRPS. So this is where a patient's got established CRPS, and there's that challenging discussion about further shortening a lower limb, for example, and then doing TMR and RPNI in that surgery is believed to be, because it's very difficult because there's no control subjects to actually identify how influential these strategies are. But we have patients where the pain is significantly reduced, and it's believed to be because of these procedures.
And finally, what do you think the future holds for the management of neuroma?
So I think what we ought to do is actually evaluate and look at what we actually have, rather than looking for, again, a magic bullet. We should look at the established strategies we have end to end, versus the use of nerve conduits versus direct suture repair, for example, versus TMR versus RPNI, and doing trials. The problem with this is that you don't have a very good control group, and it's very difficult to see how useful the strategy is that you have chosen. We talked about biomaterials such as nerve conduits and nerve caps. I think that they will become more advanced. But there's also stem cells. So it's all about signaling. So how can you apply treatments that will cause the nerve to heal in a better way, or repair damaged nerves? There's also electrodes as well. So these are basically implantable devices where you can then, like a human sort of computer interface, where you can try and aim to manage one's pain with a central nervous system. So it's a device that's always sort of almost switched on, and is communicating with the central nervous system to just calm things down. These are all very much kind of, blue sky strategies. But I think as surgeons, the key is that index procedure and preventing neuroma development, and for all of us to be a bit more open and share our complex cases and difficult cases, and to find the techniques that will work. And the thing that I really like about RPNI and TMR is that these aren't approaches where we have to now implement ethical approval and bring new things in. So, for example, RPNI is currently under review by NICE most recently, and they're going to approve that as a treatment strategy for patients, that are amputees where you're doing stump revision. And so I think what's quite nice is we can actually do these procedures now. But the important thing is learning how to do them properly, which is why I think we just need an open forum for discussion and discussions like this on the podcast. There is a trial, so it's called Connect, which is comparing different end-to-end nerve repair strategies, including conduits versus direct suture repair as well. But my feeling is that to compare one patient who has their own pathophysiology compared to another patient, especially when it comes to nerve, which is very complex, is a challenging thing to do. But any trial that we can do may be useful.
Fantastic. Well, thank you very much to both of our speakers. Some really interesting content there, and I certainly learned a lot. Thank you to both of you for your time.
Thank you, Matt. It's been a great experience.
Yeah, no, thank you. It's actually been, I think, a learning experience for me as well, because I've learned a lot from Kavit and what he said, and in his the information he's got from his research and such like. I would say that for our trainees listening to this, there's an excellent paper by Eberlin and Dukic from 2018 called Surgical Algorithm for Neuroma Management, a Changing Treatment Paradigm. It's in PRS Global Open, so it's free access on the internet. It's a really nice overview article on neuroma surgery, and I would very much recommend that.
So actually, on that note, there is a book called Contemporary Neuroma Management, which was released last year. And similarly, it's by the same authors. So Eberlin, Dukic, Amy Moore, Paul Sederna, Gregory Domanian. So these are big names in peripheral nerve surgery. And basically, it's a comprehensive book looking at traditional treatment managements as well as those that are more new, and going through a case-by-case discussion to highlight the different techniques that you can use with a full colour atlas.
Thank you to both of you, and I will definitely have a look at that. All the best. I hope that's been interesting, everyone.
Podplast UK is a collaboration between UK plastic surgery trainees and consultants. The content reflects individuals' practice and opinions may vary. If you have any feedback, do get in touch. We hope that this has been interesting and useful. If it has, remember to follow us for future sessions.